Let's start with the x-rays. And what we want to do is just really connect the dots. And, okay, what would we typically see on an x-ray? What would be a typical diagnosis? What would be some other possible findings? What would be the therapeutic protocol? And would there be an impairment rating or not? So we'll just kind of walk through. So let's take a look at this series right here. So we are looking at a series. So let me walk through so you can get an idea of all the pictures here, and we'll come back to this one. So we got flexion, extension, obliques, left and right lateral bending, and APOM, left and right lateral bending. And let's say it was an auto accident. Okay. Low impact soft tissue spinal injury. Okay. So we're going to look at this picture, cervical lateral. First thing we're going to be able to see, obviously, right away is hypolordosis, no organic problems, no other lines of mensuration issues. So we're just going to kind of put that on the back burner. You know, if that was a standalone by itself, it wouldn't be that big of a deal. So let's just keep this in mind. But remember, this is an add-on. Remember, this is a stationary, so you can add this as a range of motion, one person impairment, whole person impairment added to a primary impairment. So we're going to keep that in mind as we walk through this. And remember, it's added, not combined. Okay. So having said that, let's go. We got a flexion view here. So without doing lines of measurement and taking out a ruler, we're just going to be eyeing it right here. And I'm going to look at the motor units. So if we're going to look at the motor units for flexion, so remember what we're looking for is greater than 7 degrees or 11 degrees is what we're looking for. So if we go into flexion, we'll see the motor units. Okay, so let's say if we look at C2, C3, that's not much movement there. C3, C4, some movement. Okay, so I'm not seeing anything there. And George's line looks pretty good going all the way back. So I'm not seeing any disruption in George's line. Okay, and the ADI is fine. All right, now we go into extension. And as we come back, let's look at George's line. Are we seeing any disruptions? Not really. Not really. You could look at, what is that? 1, 2, 3, 4, 5. You could look at 5 on 6, and you could see there's definitely a little bit of a disruption, but I'd have to measure that to see what we're looking at. Okay. So remember, with translation, we'd be looking at greater than 1 millimeter. So that's possible. That's greater than 1 millimeter. Looks like it's not going to be greater than 3.5. And then if we're going to look at hyperflexion, hyperextension, is it greater than 7 degrees or 11 degrees without drawing lines and measuring them? We're going to say probably no. So let's hold off on that one too. Okay. Nothing really obvious except that maybe 1 millimeter translation on C 1, 2, 3, 4, 5. Left oblique looks fine. Not seeing anything there. Holes are pretty good. Okay. And right oblique looks fine. And we go to the AP. So just some little bit of head tilting, but nothing organically I see here. Facets, joints, spinous process, bifid. Okay, so nothing there really to capture your attention. Okay, now that gets a little interesting right there. So we got right lateral flexion, and we're looking at rotation. So it is rotating to the opposite side. But you see a huge deviation right there at what, 7, 6, 5, 4, between 3 and 4. That really slips out a lot more than 2 and 3 or 4 and 5. So that one segment, you can definitely see that is that is definitely hyperlaterally flexed. And that looks like it's C3 if you count up from the bottom. T1, 7, 6, 5, 4, 3. So it looks like it's 4 on 5 possibly. So we got T1. So 7, 6, 5, 4, 3. So it's 3 on 4. So I'm just going to keep a note on that. I'm going to keep a note on it because remember, we're looking at associated findings also. So we definitely have an increase in lateral flexion right there, right lateral flexion. So I'm just going to make a note of that. So right now we are looking at lateral hypolordosis. Hypolordosis lateral, there's some potential there. We're looking at C3, C4, right lateral flexion. Hyper, that's obviously would be a hyper compared to the other ones. Nothing with rotation to speak of. And then look how there's no movement. So when there's left lateral flexion, you can see the body's moving, not the neck. The motor units are about stovepipe as they can get. And I'm not seeing any rotation there. So when you come up from T1, C7, C6, C5, so we definitely have minimal. So this is left lateral flexion. So this is hypo lateral flexion. And I'd say easily from that C4 down, C4, 5, 6, 7, C4 down to C7. And we are seeing rotation at C5, but we see it down low, it's not. So those lower vertebrae, 7, 6, 5, there's no rotation. So there's no left rotation on the lower segments. Remember, those vertebrae should be rotating to the left. You can see it's like a stovepipe on right lateral flexion. So there's no left rotation for the spinous processes there. So let's see how this adds up a little bit. Now we're going to look at the APOM. And with the APOM, we're obviously looking for if it's translated off to the side or not. And then we go to the right lateral, and it definitely does to the left. So we have left APOM. So this would be like a T-bone injury or somebody who turned her head while they got hit from behind. So we definitely have left API, and that's not a little, that's significant. That's definitely 3 millimeters or more. So we definitely have a significant injury in the alar ligaments and left lateral flexion and right lateral flexion and right lateral flexions. So we definitely have slippage here. So of those findings on the x-ray, that's the big one right there. It's obvious, easy to see, and it's the big one. Okay, so we've got APL, we've got left and right lateral flexion, APLM. So we definitely have an impairment rating going on here. We'll get to the impairment in just a second. We also have no left rotation, so that's going to be a potential secondary finding. We've got hypolordosis at C7. That's from the AP view. That's going to be just a secondary finding. And then you got C4 right lateral flexion. That's hyper C3, C4. And we have hypolordosis. So we got several things going on here in the spine. We definitely have some altered spinal biomechanics going on. So if I'm going to prioritize this right now with not even considering any other findings, the main thing that I'm going to be paying attention to with this right now is what was the mechanism of injury. That's number one with everything. In other words, everything should start lining up with mechanism of injury and the plane of injury. Remember, that's where you need to be looking. That's where you need to be focusing. What was the mechanism of injury? What was the plane of the injury? And when you do all your diagnostics, etc., pay a lot of attention to the plane of injury. So we definitely have ALMSI. We have some secondary no rotation. We have hypo, AP hypo movements, and we've got hyper with right lateral flexion. Okay, so these are going to be secondary, and we have hypolordosis. So we have several structural secondary findings going on here. Okay, all right. So having said that, let's come back up and look at some of the other diagnostics. So let's go ahead and look at, having said that's the x-rays we're dealing with. They were in an auto accident. Let's go ahead and look at some of these other findings. What would we suspect to find with some of these other checklist findings? Remember, you should already knowing the plane of injury and the mechanism of injury and the plane of injury, front, back, left, or right. Okay. So having said that, mechanism injury, we'll make sure and evaluate if there's a pre-existing injury. Remember, when we do that, was it the same location? What was the intensity? What was the frequency? And did it affect any ADLs? And did they have it within the last 12 months? So let's say there was not. Let's say that there was no pre-existing. Okay. So you go into the subjective findings. Let's say that there are subjective findings at MMI. And by the way, let's differentiate between maybe initial findings and MMI, because those are very different. So patient signs, would we typically see any height or weight changes? Not really. You might see a little bit of weight changes if the patient's at MMI and they've been sedentary for a long time, they gain weight. Okay. Will we typically see very many pulse changes? You could see a pulse change if you'd seen the patient somewhat relevant after the accident, right? But otherwise, no, that wouldn't be much of a finding. Same with blood pressure, or if the person was in pain when you did it. But in MMI, are we going to see a pulse change? No. From the beginning, we may, again, it depends if you caught it right at the time of the accident. Same with blood pressure. And are those going to be significant findings in and among themselves? No. Are they going to be important secondary findings? Well, they're going to be important secondary findings, especially when you have multiple secondary findings. Then adding these two in, a weight differential, or if you can show a pulse difference and a blood pressure difference when you initially took the patient in versus MMI, those differences, especially if it stayed elevated, if it stayed above average, then that's gonna add in a little more weight to the picture. Okay, we go to physical signs. We're just going to take a quick look over your physical signs. Is there any antalgic guarding, bruising, scratching, and take any photos if you are. Are there typically these types of on the initial exam? If you find the patient right after the accident, yeah, usually there is a little guarding, some antalgica or Adams sign when they get in and out of a chair or something, like, they protect themselves a little bit. So you just need to be a little bit aware of physical signs. Is there a little antalgica? Is there a little guarding? Now, is that going to be there at MMI? Probably not. Probably not going to see. You could see maybe a little guarding. But are you going to see this at MMI? Probably not too much. So we don't have a whole lot here. But remember, it's about the pyramid effect. We're looking to build something, because we definitely have some findings here, but we need to build around it. We need some other primary findings and other in the same category or outside the same category. And we definitely need secondary findings. When we definitely have secondary findings within the same category X-ray, but it'd be good to have primary and secondary findings outside of the X-ray category that support this. That's really what we're paying a lot of attention to right now. There's a potential case here. We're looking to build it, is what's happening right now. Okay, so you go to hybrid evidence, range of motion, active range of motion. So let's talk about that first. Would we typically see active range of motion, some limitations initially on the initial exam? Probably. At MMI, maybe not. There's a good chance you would not. If you did, where am I going to pay attention to active range of motion with this patient is left and right lateral bending. We've got ALMS, we've got lateral flexion problems with that lateral mass. We got rotational problems in lateral flexion. We got rotational problems. I'm paying attention to left and right lateral bending with this patient and those tests. So I'm going to be paying a lot of attention to the active range of motion and left and right lateral bending. Where will it be restricted at MMI? At the end. Remember how ranges of motion are affected first, further out, and the worse they get, it starts to increasing it, and it starts decreasing the active range of motion closer in. So are we going to have passive over range of motion pressure problems? Almost definitely. Almost definitely. And in the left and right lateral flexion plane of motion, that's where you're definitely going to find them. Next is muscle strength. Are we going to have muscle strength issues? I think what will happen with this case is, and you could have initially just because they may have been in pain, but at MMI, would you have a muscle strength case at MMI? This is one of those cases that I think you would not, if you just did a normal muscle strength, I think you would find it 5 out of 5. But I think if you put your finger on the atlas or axis and then retested the muscle strength, the cervical muscle strength and flexion extension, and again, what am I going to be paying a lot of attention to with muscle strength? Lateral flexion. But I'm guessing if you put your finger on that spinous process of C1, C2 and applied a little pressure and then you retested left or right lateral flexion, I'm almost will guarantee you that muscle will go weak because of that lesion. So you had to know how to, that's called high specificity testing. In other words, if you put your finger on somebody's atlas and you tested their strength in their neck muscles, if they were 100% healthy, shouldn't they have 100% strength? And the answer is yes. So this is when you have to do the high sensitivity muscle strength test. And I will almost guarantee you will get a positive out of that. Now that's important. Why is that important? Because it's another category. Remember, different categories that correlate and associate with the main injury become very important. So this would be a huge finding because it would be another category, a different category that is directly associated with the injury. Okay, so we go to neurological. What's your chances of having dermatome aberrations? You're not. Reflexes, you're not. Cranial nerves, you're not. Coma scale, typically not. Let me get to the coma scale in just a second. So remember, dermatomes can fluctuate a little bit. They're typically not pathological when you do get them as a chiropractor from a low impact soft tissue spinal injury case. Same with reflexes. They can be slightly aberrant or initially maybe more sensitive. But remember, what matters is that MMI. That's what matters is MMI. So I don't think so. In my experience, I don't think you're going to see dermatome or reflex issue here or a cranial nerve issue here. I don't think you are. Glasgow Coma Scale is interesting because this is going to go back to the mechanism of injury. And I'm sitting here going, wait a minute. We've definitely got a neck injury. We've identified it as a car accident injury. And we have lateral flexion malposition at the transverse ligament up high. And remember, that's a significant injury. It's significant because you have very little space in the spinal canal at that segment. So, that's way more important of an injury or significant of an injury than if it was at C5, C6, there's a lot more canal space. So what I'm going to be paying a lot of attention to with that Glasgow Coma scale, I'm going, well, I'm looking specifically, did the person see stars? Did they blank out? See, those are all signs of a concussion. Did they see stars, or did they black out? Or did their eyes get blurry vision upon the impact? That's what I'm going to be paying a lot of attention to in this consultation. Now, if they did it all, because you got the mechanism of injury and you got the associated findings, I'm going to follow up with just a couple more behavioral questions. And by the way, if they did see stars or blacked out for just a second, I'm immediately getting a behavioral examination from the neuropsychologist. That's where you're going to find any findings with head trauma with low impact soft tissue spinal injuries. It's not going to be on a CAT scan or an MRI. But since I'm dealing with a head injury and I've got significant LMSI, I'm paying attention to this now. You see, I'm focusing my direction. I'm not just going through tests to do tests. I'm paying attention to this, to the coma evaluation. Now, I don't think you'd find anything with the Glasgow Coma scale. That's really for significant injuries is what you'll find. But as soon as they said anything about blacking out or seeing stars, that's a brain bruise. That's a coma. And then I'm going to ask about behavior, any irritability or personality changes. Now, the person I'm going to ask that to is their spouse. The patient typically won't know it. I'll ask the patient too. But I'm going to ask the spouse, have you noticed any change in their personality? Are they more irritable, or do they go off easier? Those are some of the common findings. Now, if I get yeses to any of those, they're more irritable, especially with this type of injury. They're more irritable. Yeah, he seems like he's a little more in depression. Seems like there's a little bit of a personality change. I'm definitely, and the person had saw stars when they were impacted. I'm definitely getting a neuropsychological exam. That's where you're going to find the problems. And that's big. That's a big case. You find some aberrant findings with the behavioral examination test. So remember, a neuropsychologist is typically the ones that'll do trauma. They're behavioral tests for trauma is what they are. If you don't have a neuropsychologist, just contact some psychologist in the area or even down at the university. Contact your local university. They'll be able to put you in the right direction. Contact the psychological department and say, hey, who does behavioral testing for physical trauma, to document physical trauma, like the behavioral testing? And they'll be able to get you to some, even psychologists. Some psychologists will do behavioral testing for physical trauma. Okay. And those are peer-reviewed. Those are medically accepted, peer-reviewed. So if that's the case, you just added a significant addition to this case. That's what I'm going to be paying attention to when I ask about the coma potential or the mild concussion potential. Okay. So don't underestimate that. Remember, about 10% of the cases have that. And here's the other reason it's important. It's neurological. Juries, especially juries, put a tremendous amount of weight on neurological. You would not only have the behavioral testing, but you would have all the primary and secondary evidence of the physical trauma to the concussion with these x-rays and these other tests. So this is a potentially very big case. So be aware of it. But this is how I'm looking at it. Okay. All right. So let's go to the cervical test. So what are the common tests that we're going to do in the cervical region? Direct compression, distraction, foraminal compressions, Adson's, shoulder depression, Wright's. So we'll add Sperling's in there, Tennell's. Phelan's. Those are the most common ones. So what would typically be positive in this? And remember, you want to grade them not only in their standard grading of positive or negative, you want to grade them in with the functional capacity index, because there's a big difference between a grade 3 on initial exam and a grade 1 on initial exam. Okay, so make sure when you grade orthopedic tests, you're using the functional capacity grading scale. So direct compression is would I probably have that? That's possible. That's more for disc. Same with distraction. That's more for disc. But with those facets the way they are, I'd say there's a high chance you're going to have a positive direct compression. And it could be either way, because the distraction would relieve the pressure from the disc, but it's pulling the ligaments. But direct compression is compressing the facets, and so you could have either one of these two or both of them being positive, whether it's facet, disc, or ligament. See? All right, so I'm saying that we're probably going to have something there. And then foraminal compression, I would say definitely. Remember, that's the most important test because it evaluates 3 planes of motion in overpressure: lateral flexion, extension, and rotation. That's why it's the most probable. Now, that's if you do it right. I found most doctors don't do it right. They only do 2. They'll only typically do 2 planes of motion and barely get into overpressure. So be careful about your ergonomics of how you're doing your orthopedic test. Adson's brachial test, Adson's test. That's checking the brachioradialis, neurological or vascular. Are we going to have anything with that? Probably not. Probably not. But I always say do it, because you'd be surprised how many times even though the patient has no tingling or numbness in arms or hands, you would be surprised how many times you do that test and you'll elicit tingling or numbness that'll start to happen unilaterally. You'll be surprised. Is it going to be directly related? Is Adson's going to be directly related? No, it's going to be a secondary test, because that's a vascular test. That's a neurological vascular test into the extremities. Okay, shoulder depression, that's kind of a catch-all, right? So there's a good chance you'd have a positive shoulder depression test just because you're stretching. If you just tilt the head, laterally flex it, tilt it, and push, you're going to be pulling on those ligaments. So that alone gives you a high probability. Wright's test for circulation, no. Tennell's test, no. Phelan's test, no. So in all likelihood, you're not going to have anything with those. You could, but you probably won't. Go to the lumbar, and let's just say this was just a cervical injury. So Kemp, Sittingberg, DeRuze, Lessegs, Braggers, Patrick Faber's, Milgram's. Milgram's is for an intrathecal pressure. Is it possible that you have that? Possible. Is it probable? No. But let's say this was just an upper cervical region problem and no lower back problem. Okay, palpation. Now, remember, we're in another category. Remember how important it is to have separate categories, either primary or secondary evidence that point to the main cause. So, palpation. Am I going to find some joint fixation in those x-rays that I just found? Heck yeah. Heck yes. We definitely are going to find. And then remember, I want to identify them. What motion am I feeling? C5, C6, C3, C, whatever it is you feel, identify, and then identify the fixation. And remember, you can grade fixations with the functional capacity index. You can grade it. Remember, if it's 0, it's no problem. 3 is you try to do the test and they won't let you. So if you try to palpate and they won't let you, that's a 3. So it's typically going to be a 2 or 1. 2 is you can do the test, but they kind of guard. And 1 is you can do the test fully, but it's tender or painful. Okay. So what's the likelihood I'm going to have a positive fixation grade 1 or 2? Real high. And it's going to be specific for that involved area. So, and that's a hybrid test. Okay. So that's going to be real high. That's another one. What's the chances I'm going to have tenderness at that fixation? Real high. Okay. What's the chances I'm going to have muscle guarding? Real high. I'm going to have a lot of intrinsic muscle guarding here. It'll be a lot of times the smaller muscle groups. Now, this becomes real important because we're going to do a dynarom test also. So if we're palpating and we feel some muscle testing, and then remember, we always want to list the regions: cervical, unilateral, bilateral, and then what plane of motion: flexors, extensors, left lateral flexors, right lateral flexors, left rotators, right rotators. You always do muscles in the group of the plane of the motion. That's how you want to identify muscle strength or muscle spasms. Okay, so you got muscle guarding. Yes, I'm going to say we're going to have some tension. I'm going to say definitely. With those X-rays, definitely. Okay, and then grade them. So that would be and use the functional capacity grade again, 0, 1, 2, 3, and you'd probably definitely be at a 2. You'd probably have some guarding when you started pushing in there. But my point is, this becomes real significant. So there's one finding on its own is no big deal. But now, if you did the muscle strength analysis properly and you found the muscle strength weakness in the plane of motion, and you have muscle guarding, and you have a positive dynarom, all of those in the muscle category, that is a big finding. All three of those together and then tied to the X-rays and the other findings. So you see, this is starting to get to be a big case, if not big, very good case is what this is starting to look like, because I'm specifically looking for these and documenting these. I'm not just randomly doing tests. Okay. I'm paying a lot of attention to overpressure joint motion, because remember, most of the problems are in overpressure, especially joint motion at MMI. That's where all the problems are. So having said that, we'll have a positive fixation, tenderness, so we're going to have all three of those at high likelihood probability. Well, now we're going to have some functional capacity indexes. Now in the neck, so we're going to be paying attention to the neck disability index. So remember, what are we paying a lot of attention to with these functional capacity indexes is overpressure range of motion. Not that they can just do something with active range of motion. Most people will. And if they can, I'm going to pay attention to active range of motion in the plane of motion. So like this patient, I'm paying attention to left and right lateral flexion with the ADLs. What ADLs are they doing in that neck disability index that are involving lateral flexion, especially, and overpressure in lateral flexion? That's where I really want to focus my attention and that patient's attention on getting that documentation. All right, now we come to the X-rays. We already talked about the X-rays. We definitely have ALMSI, or not ALMSI, but we definitely have lateral flexion malposition. We got some stovepipe fixations. We got rotational problems. And then we have hypermobility and hypo with static. So we got some dynamic issues, primary, secondary dynamic issues, and we got a static issue. Okay, so all right, so let's go to the next one, blood test, high C-reactive protein. So what's the likelihood if the patient has a positive foraminal compression test, positive overpressure test, positive tenderness on palpation, that they're going to have a positive high C-reactive protein? It's pretty high. So this becomes huge. Why has it become huge? Because it's another category. It's not primary. It's secondary, but it's huge because it's another category and it's a blood test. Blood tests are well trusted. Now remember, that blood test on its own would be relatively insignificant. But how much mountain of evidence have we created up to this point? So this blood test with this particular patient and all these findings that we've already found becomes huge. Do the blood test. Now, what's the likelihood you're going to find sedimentation rate? Probably not. C-reactive protein, yeah. High probability. Do the test. Order it. And then we'll go to Dynaron, which is another huge test. And I would definitely want to make sure I get this because I already have muscles. I've got the mechanism of injury. I've got the spasms. And I've got muscle weakness. So I want to make sure I get this Dynaron test. It's going to show objectively all the erratic firing. So remember, it's primary for muscle spasms, secondary to support ligamentous lesions, altered spinal biomechanics, because that's what causes muscle spasms, is altered spinal biomechanics. So you can see we have another huge test here. All right, go to MRI. We're not going to find hardly anything, pretty much nothing with an MRI or CT scan or an NCV or an EMG pictures. You may have, we talked about that earlier in the initial structural analysis. Have you seen anything? And then did the patient perform home therapy? Now remember, when does home therapy become very, 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 very important? When the patient did not seek immediate medical care. Remember, when there's an accident and there's a lapse of several days, or definitely if there's a lapse of more than several days in a week or two or more, this becomes paramount that you dig and you find these home therapies that they've done, because it says, yeah, they were getting treated. They just didn't get medical treatment. So this is huge. Rest. Did they rest more? And document the rest. How much more often? Remember, you always want to quantify. You want to quantify. How much more rest and how long did you rest? Ice packs are heat therapy. Again, quantify. How long? How much? How often? Did you restrict or alter movements? Remember, that's the first thing people do when they get injured. They just restrict going into that plane of motion. That hurts. But they'll forget it. You got to remind them. Well, did you stop tilting your head to the left when you did all your activities, and then place them through common activities of daily living, especially in the neck disability index? And that's what people do. Well, unless you specifically ask for it, you're going to miss it because they won't remember it. And I'm also going to be focusing on left and right lateral flexion. I'll do all the motions, but I'm going to pay a lot of attention with ADLs and left and right lateral flexion because of the movement of that atlas on axis. Supplements. Sometimes people take supplements to help them. Did they? What was the amount? How often? Or over-the-counter pain medication. That's a big one. You got to be careful and not say, are you taking any pain medication? Because they think it's prescription. When you say that, they think prescription drugs. You've got to specifically itemize out when you say over-the-counter. Are you taking any over-the-counter medications such as ibuprofen, aspirin, Tylenol, anything like that? See, most patients take them like candy. They don't even think of it as a drug. So you can't just say, are you taking any medications? And again, you want to know the amount. What was the frequency and the amount? See, all this becomes really important if they didn't seek care for 1, 2, or 3 weeks. They've rested more. They use an ice pack every now and then. They restricted movement, and they've been taking ibuprofen daily since the accident. Well, that's a big deal now. See, a jury's going to relate to that big time. And chances are they had to work. They didn't think it was that big of a problem. They had to work and couldn't miss work. Well, this becomes major into, especially if it goes to a jury's hands. Because remember, juries understand emotion. Okay, then we go into complicating factors. Did they take time off from work? Must perform work. Remember, we talked about it's always good when you get a patient to take them off work, if anything, through at least the first 72 hours or more, just to help decrease the inflammation as fast as possible in that time period. So complicated. Did they take time off from work? And then if they didn't, you want to make sure that you documented why they didn't, because that just doesn't look good that they had this injury and had all these injuries. And you're trying to show all these injuries and they didn't take any time off from work, or you, the doctor, didn't take them off from work. So that's why you should have taken them off, at least for the inflammatory phase. And if they couldn't, you should have written it down that I requested it, and then the reason why they couldn't. And a lot of times they can't because they're afraid to lose their job, or they're afraid to lose the money. Those are real reasons. Those need to be documented. So you need to be either document, you told them they did or they didn't. And if they didn't, why they didn't. And that's usually the reasons why. But you got to dig for it. You can't just hand them a sheet of paper, take it back and put it in their file. Must perform activities of daily. A lot of times they have to do the activities of daily living that cause them problems. You want to find that out. Did you have to? Did you have to work? Could you work part-time? A lot of times I'll ask them to take off. If they can't, I'll say, can you work with limited exertion? And then from there, and then I'll still document they couldn't take off. I recommended they take off or limited exertion, but the patient couldn't because they stated they're afraid they get fired if they lost work and they can't afford to lose the money. That's like 80% of your patients, that phrase I just said. Did they alter their behavior? Now, when we say alter their behavior, we're specifically making it relevant to that injury. I'm not just going to look at the whole body. I don't care if he altered their behavior with their lower back. It's irrelevant. Altered the behavior to me, I'm focusing on the neck. Did you alter, and what part of the neck? The plane of motion of the neck. Well, what plane of motion am I paying attention to with this patient? Left and right lateral flexion. So did you alter your movement with your neck going from left to the right? And I'll go through the list of those ADLs in the Neck Disability Index. That's exactly how. And I'll find it that, yeah, they did limit it going left or right with those activities. And then we talked about medications. If they are on prescription medications, and remember the name, amount. You always want to get the name of the prescription, the amount, and the frequency. Always, always, always. Okay. Those are some common ones to pay attention to. NSAIDs, muscle relaxers, anxiety medication. Okay. So we got a lot here. Man, do we have a lot. This case is built up quite a bit because we dug and we paid a lot of attention to these high sensitivity, high relevancy diagnostics. So remember, if we look at the 7 minimum categories that you need to stop a low ball offer and to create a high value injury ward. What's the minimum 7? Well, mechanism of injury, check, got that. So subjective findings at MMI. Let's just suggest that we do have those, and let's say we have at least primary and secondary, because in all likelihood we do based on what we saw with those x-rays. Hybrid, check. We got primary and secondary findings in hybrid. Subjective findings, check. We got x-ray, right? We're going to have blood test. We're going to have dynarom. All right, so we got some that's objective. And in the hybrid category, we said we would have possibly, there could be some definitely with the orthopedic test, with the ortho test, with the muscle test, with palpation. You're going to have primary and second, and then so you got primary and secondary in multiple categories here. And between the subjective, not just how they feel, but did you analyze it? Did you see any antalgica or anything like that, guarding, anything like that? So we're sitting here on several categories. We got several primary and secondary categories in subjective, hybrid, and objective. This is and with the mechanism of injury. And I have not even included injury magnifiers. Chances are they're going to have an injury magnifier, but that's not one of the mandatory 7. So that would just be added in. So you see how this case is getting bigger and bigger. And then we go, okay, did they reach MMI? So let's say yes. And then that takes us to the impairment rating. You go, okay, what impairment rating are we going to do? Well, we got a lot to choose from, right? So we had the big one. You're always going to start with the big one. Is we're going to go with the APOM. We're going to go with lateral flexion with the transverse ligament, left and right lateral tilting. That's obvious, gross and obvious. I'm going to measure it. That's easily 2 to 3 millimeters on both sides. That's a serious, significant finding because of the central canal size. It's not going to take much more before this person has another injury and gets paralyzed. Okay. So we did, and then we got some minor findings with the joints locking up and lateral flexion lower. We have hypermobility at C3, C4, and we have decreased rotation, spinal rotation, and we have hypolordosis. Okay. Now you got to be careful here. So let's go to the impairment rating now. Let's pull that up. Now I'm going to go to the impairment ratings. Okay, well, remember the first and easiest way to do an impairment is to eliminate what they're not. So I put on here this chart, and we'll expand it a little bit here. But essentially I just eliminated some areas, okay? But the first one that I'm going to go with and pay attention to is the lateral flexion. Now it's not on here. So here's the DRE chart. And does it say left lateral flexion, alar ligament? No, it does not. Does that mean it's not an impairable rating? No, it does not. I can't list every impairment under the sun. That's why it's called guides, not rules. So now you have to go, okay, let's narrow down the funnel. Go, where does it fit? Well, we know it fits either here in category 2 or there's potential for category 4. Category 4 is LMSI when it lists, the millimeters of translation with flexion extension. Doesn't say anything about left or right lateral flexion. Okay. And here it has muscle guarding, asymmetric range of motion. So we're fine there. Okay. And let's say there's no or muscle strength. So there's potential here in category 3. Because let's say we got muscle strength weakness too. So we had a residual. So now we're looking at possibly 15 to 18% or 30, 25 to 28%. And you go, now how does that relate to the range of motion? Well, when we come to the range of motion, it's a lot smaller. We come back here to the category here, and it's just given 4, 6, 7, 8%. So much smaller. So those are my options just from the process of elimination. So I'm going to come back to the LMSI category is what I'm going to do. I'm going to come back right here. And remember, you need to be able to justify this while you're doing it. And I got to tell you, the problem that I see right off, to be honest with you, with these impairments, is I could see you trying to create too many impairments, too big of an impairment. Remember, you can easily lose credibility by trying to give some ridiculous impairment rating, okay? And this is one of those cases. This is one of those cases that would be very easy to give a ridiculous impairment rating. But I don't want to lose credibility. This case has everything. I don't need to lose credibility. It's got all the categories of all the documentation boxes checked. I just need to make it solid. That's it, okay? So I'm going to start with lateral flexion malposition because it's the most important injury. Now, it's not directly in there. So I've got 3 options I could go to. I could go to the range of motion. I'm not. I could go to DRE table 2, and I'm not. Or table 3, and I'm not either. I'm going to go to the DRE category 4. I'm going to the MSI category, and here's why. I'm going to now, we measured it, and let's say it was 2 or 3 millimeters, but those measurements of 2 or 3 millimeters aren't relative to these measurements of 2 or 3 millimeters in flexion extension. What is important is that it's 2 or 3 millimeters, and it's bilateral, by the way. It's not unilateral, it's bilateral. That's significant. And so I'm going to call it AOMSI of the transverse ligament. It's bilateral. And the reason I'm going to go there is because of the severity and the injury. That's why I'm picking category 4, not category 3 or 2 or the range of motion. And it does, by the way, give the most impairment rating. It does do that. But remember, that doesn't matter. What matters is, can you justify it? I'm giving it there. It gives the most impairment rating, and I can justify it because that's a serious injury. That's the smallest area of the neural canal for the spinal cord to go through that has the least amount of free motion to give before there's paralysis. So 3 millimeters loss in the central canal at C1, C2, or occiput C1, that area, is way more significant than losing 3 millimeters of flexion extension of C5, C6, because the neural canal is bigger. So there's more to give down there. That's why I'm going with LMS. I'm going with category 4. On a percentage basis, this is way more serious of an injury than the flexion extension at 3.5 millimeters, because it has way less space. And if you were to measure the space, you would see that, it'd be a significantly larger percentage of space occupying lesion in the neural canal. That's why I'm going there. Now, the next question is do you go from 25? Do you go to 25 or 28? Well, remember, the difference is the quantity and quality of ADLs. Quantity and quality of ADLs. How many ADLs do we have positive at MMI? And how many of them are important? Well, let's say this person is average. Let's say it's not high and it's not low. They definitely have some ADLs. So 25, 26, 27, 28. So I got 4 potential impairment ratings. So if I had a lot, I would say 28. If I didn't, then I wouldn't. So I'm going to go ahead and now this is a serious injury. So you could easily say, I'm going to give it a 28, not only because it's a serious injury combined with the ADLs, see, and then you just justify the seriousness of the injury. So you could definitely do that as long as you justified why you did it. So I'm going to say 28%. Not only is it affecting, quantity and quality of ADLs, but the seriousness of this injury. Okay, so let's say I put down 28. So I'm at a 28% impairment rate. So can I give more than that? Well, not from these tables. I can't. I have these other findings, remember? I've got hypolordosis, hypermobility. I've got several of these other factors. Well, where are those to be found? They're to be found right there. They're to be found in the range of motion. Remember, are you allowed to add DRE and range of motion for an injury? Yes. The guides prefers you to use DRE over range of motion, but if you can't find it, the fit exactly or the best for the DRE, then use the ROM, and you can combine them. So here we go. We come in here, and this is where you can get carried away right now with impairments. See, right now I'm sitting solid. I've got great documentation for everything. I got a good impairment rate. Right now is where you could go overboard right now. And this is how. Well, you go to table 2, it says intervertebral disc or other soft tissue lesion. Diagnosis must be based on clinical symptom, sign, or imaging. We've got that. This is the cervical region. And this is unoperated on, no residual symptoms. Now look at B. It says unoperated on. With medically documented injury, pain, and rigidity associated with none to minimal degenerative pain. Now you see that asterisk right there. Well, when you come down, you can't see it down here. Let me see if we can pull it up. That asterisk says structural tests include radiographs. That's what it says right down there. That's what this asterisk right here means. Structural test. Well, is hypolordosis a structural test? Yes. Are lateral flexion malposition a structural test? Yes. Is rotational malposition a structural test? Yes. Is the altered spinal biomechanics of C5, 4, 5, and 6, and 7, that they're all fixated together on lateral flexion? Is that pathological? Is it a structural test? Okay. So that's why I say you could easily go overboard. Now, what are they giving you? Well, it says, if you have these, it says add 1% per level. Okay. Now, if it says, if there's operations, multiple levels with or without operations, with or residual symptoms. So this says for every one that you find, you can add 1% whole body. By the way, this is whole body. And it says add, you don't have to combine. Well, this is the dilemma you can find yourself in. We got hypolordosis, so that's one. We got C3, C4, that's another one. We've got rotational malposition, that's another one. And we got the stovepiping. So I could easily justify adding 4 more impairment ratings or 4 more impairment numbers to this. Now I'm already at 28. Okay. So now you're dealing with, a possible credibility issue. So you could put all of them down. You could list all of them: hypolordosis, hyperflexion, rotational malposition, and non-rotational and lateral flexion. And that fits right into this table, category 2, section B. And it's right there. It says add 1% per level. You could easily do that. And then you'd be at 32%. And that, to be honest with you, it might not be that bad, because look how much evidence you have. So you might want to do that. Because now the only reason I'm saying do that is because we got a lot of evidence. Look how many hybrid findings we have, are objective in the different categories. Look how many hybrid findings. And see, I wouldn't do that if I didn't have, just all this other stacks of information. So you definitely could do this. And remember, we're still left out on the coma behavioral testing. We don't know. And I'm going to leave that out right now, because that's going to give you another 6% impairment rating if that comes back positive with the behavioral testing. So I'm going to say a couple options here. And then you could really be getting in. So if you had 32 plus 6, you're at 38. You do have a lot of documentation, but do you want to put this person at over a 1/3 impairment rating for this? See, you better have stacks of all this other good information if you're going to do that. I prefer, since I'm already sitting strong, is not to go out on a limb with the credibility. That's my preference. I'm already positioned real well. So, but out of these 4 categories, I do want to acknowledge them. I don't want to not give them credibility, because there's something to these. So I'm going to come over here and I'm going to use one of these. How many of these I'm going to use is probably the question, but I'm going to use it because there's 4 of them here, and I don't want them just to think that that's nothing relative to this case. So you've got hypo, you could easily go to 28, 32. But if you get another 6% for that coma, if I wasn't getting another 6% for the coma, I would add all these. I'd take it to 32. Because I've got so much solid documentation. But to get it up to 38 for this injury, you're pushing the limb a little bit. You could do it though, and you could justify everything. So would I want to include hypolordosis? Would I want to include the lateral flexion? Would I want to include the rotational malposition, the structural? And if I did, which one of these would I consider more important and relevant to the existing case? Well, hypolordosis, not really. The stovepiping at the bottom, not as much, because this is a movement. Remember, dynamic is always more important than static. So I would come over here where it's, and I would add the C3, C4 hyper lateral flexion, because it's directly related to what I'm talking about, or the injury, the mechanism. It's just a level lower. That's all. So it's directly associated and it's dynamic. So I would use that. And I would use the rotation, the lack of cervical rotation. That's pathological and that's significant. That's going to cause a lot of abnormal wear and tear because those vertebrae aren't moving. So if it were me, I would just pick 2 of these and I would leave the static ones alone, to be honest with you. I'd stick with the dynamic ones. And I just gave you my reasoning why. Because I'm so high in the charts here. I got just a really good case. And so I'm going to go with 2 so that it's 1 per level. So I'm going to add another 2 whole person impairment. And I'll say why. I'm going to list the chart. It's this chart, this page right there. Everything's indicated. And I'm going to go, it's directly related to the lateral flexion malposition of the alar ligament. We're dealing with the motion dynamics and C3, C4 and abnormal pathological rotation dynamics. It's supported by x-rays. It's supported by your dynarom. It's supported by your hybrid test, your subjective and your mechanism of injury. And you probably have some injury magnifiers. So that's how I would come away. So if I did that, you're looking at, because remember, I already went to 28, the high end for the impairment. So I don't want to just do high end of everything. So if I did that, it would be 28 plus 4, 30. It would be 32 plus 6, 7, 8, 38. Instead, I'm just going to say it's going to be 28 plus 2, 30. And I'm going to say there's no mild coma. Let's say that was negative. And if it was, that's fine. I'll just leave it in at 6. And there you go. So I'm just going to, since my case is so strong, I'm just going to stick with the dynamic tests that are more relevant to the major finding. And I've got one solid case here. Now, does the attorney know everything I just covered with you? No. He's got a negative MRI. He doesn't know what to do with this case. He's getting a low ball offer, if anything at all. He doesn't know anything about all these categories and how they relate and how to put them all together. This is called high sensitivity, high relevancy documentation. Now, you're the one that's going to have to go over there and point out to them everything I just pointed out to you. You go, well, here's the checklist of documentation. Here's all the documentation the person has. Here's the 7 minimum categories that have fulfilled. I just fulfilled all 7 categories, and I've got mechanism of injury. Subjective, hybrid, and objective. And I probably have injury magnifiers. Probably have a concussion, but leave it alone. So I'm going to point all that stuff out to them. And it has to be you. You're the one, because they don't know any better. So I'm going to show them how we've got a lot of documentation to support all 7 categories. In other words, it's a solid case. Then the last piece of the straw, the next case, remember, the next question they're going to ask you is, well, what do you think it's worth? Well, that's when you have to know the basics of how to convert your documentation into the 4 injury awards. So I'm going to go through the medicals, add up the medicals of what therapies they were using at MMI, what frequency they were using, what's the cost, and what's his actuarial scale of life. That takes me, that supports my medicals. I'm going to go to the impairment. And one of the ways is take their salary, their income from the time of the accident to the time that you give them the impairment rating. That would be the injury award for the impairment injury award. So that's one potential. And then the pain and suffering is taking the same thing, their income from the time of the injury to MMI, and multiplying it times a magnifier, 0, 1, 2, 3, or 4, the severity of the accident. So in this case, I would say this would be at least a 2 or 3. And that would give a good direction toward the impairment or the pain and suffering injury award. And then for the prognosis and need for future care. And actually, I mixed up the medicals for future need of care. So I'll come back to medicals in just a second. So the future needed care, prognosis and need for future care is the therapies that were required at MMI for palliative care. What was the frequency? What was the cost? What was their life expectancy? That gives the prognosis and need for future care injury award. And then back to medicals is you're supporting the medicals with the 3 phases of healing. What were the therapies necessary for the inflammation phase? What was the frequency? What was the therapies necessary? And was supported by the biomarkers. And what was the, because remember, the third-party insurance companies will always try to even stop paying 100% of medicals. So that's why you have to show the biomarkers. So then you go to the repair phase, same thing. What were the biomarkers? What was the therapies you did? What was the what was the frequency? What was the cost? Add all those up. That gives you your therapeutic cost for the repair phase. Do the same for the remodel phase. What were the biomarkers for you to do what you did? What therapies did you do? What was the frequency that you did them? And what was the cost that you used? Add it up. And then add up all the cost for the inflammation, repair, and remodel phase. And there's my medicals expected injury award. There's my impairment expected injury award. There's my pain and suffering expected injury award. And there's my prognosis and need for future care injury award. You just got all his authority and confidence. Nobody can do what you just did. Nobody. This is when you build a personal injury empire. And then, of course, you have the ability to take this documentation and put it into the 12-step category of a narrative report. Or if it's in a deposition or trial, use the 25 steps to deliver this information in a deposition or trial testimony. And there's nobody else can do it. And this is what they're looking for. And now they're not only looking for it for their soft tissue injury cases, because they can't find doctors that know how to put all this together for all their other more serious cases with, compound fractures and amputations and discs, and surgeries. They can't find doctors that know how to put it all together. They just find doctors that talk about their individual piece of the pie. And then that's when they ask you to be the expert witness for all their cases. This is exactly how chiropractic personal injury works. This is exactly how you stop lowball offers. You stop getting patients to ask our attorneys to cut your bill. This is how you stop attorneys from them saying, you send me one, I'll send you one. When you know how to do what I just covered, they'll never, ever think of asking you to refer them a patient. They will never, ever think of you or ask you to cut your bill. Then they won't, because this is the documentation that not only stops lowball offers, it creates high value injury awards, and it gives a 3-to-1 or greater injury award. And he's not going to be able to find another person on planet Earth to be able to do what you just did. You're gold. And this is how it all comes together. And you did tremendous service for your patient. You helped and supported the attorney, and you did what you should have done in the first place as a licensed physician. You did what you should have done. You documented high probability, high sensitivity documentation. You treated the patient the best you could in the inflammation phase to decrease their pain, inflammation, and muscle spasms. You treated the patient the best you could in the repair phase to help increase and get back to normal as much as possible their active, passive, and joint motion, even though we know they're not going to get back to normal as soon as those ligaments are tore. That's it. But you still have a role to increasing their quality of life, even though we know it's already permanent to some degree. You can help lessen the permanency. And then you did the best you could with your in the third phase of healing with your active resistance and stretching exercises to increase their strength and elasticity, to decrease the likelihood of reexacerbations and minimize the permanency, even though there is permanency. So you as a physician did everything you could do then you did everything you could to help the patient. And as a byproduct, the attorney was helped also. That's chiropractic personal injury documentation and marketing. Now, then you have to know how to take this information to the attorneys who are in a state of unconscious incompetence, don't know 90% of what we just covered. And you have to know how to shift their consciousness. That's called educational sales. And when you take them through, like what we just did, the whole awareness shifts from them thinking they don't need you to you'll hurt the case to eventually you becoming the absolute authority go-to person for every case. This is even if the case isn't relevant to chiropractic. My attorneys would ask me my opinion just from an outside perspective because I knew how to put the whole case together, not one slice of the pie. And this is how you create a tremendous authority in referrals and a tremendous personal injury business. Any questions?
So, Doc, this is all great. This is wonderful, by the way. I had two questions. The first one I had: can you make the alar ligament finding and all the other associated findings work if the mechanism of injury is not directly related in a sense? Let's say the patient was just rear-ended and they didn't rotate their head to the left or the right. Can you still kind of build that story and make all that work?
Sure.
And come to that conclusion that you came to?
Yeah, sure. There's some mechanism injuries are way more specific and highlighting to certain injuries. But are you trying to tell me your body's not connected? Is that what you're trying to say? No, the body is connected. There's a lot of different venues indirectly that can be injured when you're injured. You know, but I'm going to use common sense. If the person had a foot injury, I'm not working them up for, problems in the neck. In other words, they got no neck problems or anything, but they got a foot injury, and you find, LMSI in the neck. It's irrelevant. It's not, it's not related. In other words, all these things have to line up. It's not just one thing. And the more documentation that lines up, the stronger the case gets.
Oh, would it also be sometimes a patient, they don't remember that they were looking left or right, or they looked up at the rearview mirror, or they did this. And so you're asking them 3 days later on something, or 2 days later, sometimes they don't remember 100% of everything. So,
well, that's true too, but are we going to point that out on a narrative report or deposition that this typically this injury is from a T-bone and the patient wasn't T-bone? And you think I'm going to say that in a narrative report?
No, you're going to say that.
I'm not going to be stupid. This is for you to know.
Right. So do you want, when you're getting these attorneys and they're giving you the soft tissue cases, and then they want you to be the expert, do you want them on those higher, like impact or fractures, do you want them to actually bring you in and send the patient to you to be treated at some point? Or is it just a professional component that you're the expert witness?
No, they'll start using you because you know how to put the case together.
Okay.
Remember, I teach you how to put the case together, not how to do a slice of pizza.
Right. 100%.
You remember the case I told you that it was Joe Hernandez. He was in a case. This case did have a disc injury and disc surgery. So it had a neurosurgeon and it had a GP. Who did the attorney turn to be the only person to testify in court? Joe. Yeah. Why? Do you think an orthopedic surgeon knows how to put all these categories together to support a case?
No, and they don't care to, and they won't even go to court.
Yeah, they just know their specific piece of the pie. That's all. So Joe was the featured witness. He put all the information together, They got the other people's deposition, but who did the attorney want in front of the jury? Joe, because Joe knew how to put all the information together. And that's what will happen is they'll start asking you to be involved with these other cases once you become the authority in the soft tissue injury case.
Yeah, Doc, my other question was, when you're I thought initially, when you're in the DRE category, once you choose one of the percentage ranges, you had to just stay with that, or you had to either do the range of motion category. But you're saying you can combine the two? Is that right? You can combine them?
Yeah, the guides want you to use DRE first for injuries. And if it doesn't have what you need, but the ROM category does, use the ROM. And you can combine them. Now, when you combine, remember you have to combine apples to apples, meaning whole person impairment to whole person impairment. So you can't do a partial impairment. Like some of the extremities will have a partial impairment. Then you have to add the partial impairments to get the whole impairment.
Medical or both of them.
Just remember, you can't add directly a partial impairment to a whole impairment. And when you do add another impairment rating, say you're supposed to combine them. Now, remember, there's a combine chart at the back of the AMA guides. Now, the only reason I said you can add them is because in that chart, now that's only and specifically that chart. So if you used what was listed in that chart and that's what we did. That's why and it was whole person numbers. It was not partial. It was whole person. And it said add them. That's why we added them. So be careful. There's partial, and that's
Son, I have all the reports ready for you.
so just remember extremities usually have partial. So just remember you hit everything to whole impairment, and then
treatment.
Hey, can you hold on here, guys?
Show me how to do it. I'll know how to do it in the future if I need it.
And then you do
I forget it. It's better to print them and I take them. And if you're going to do that, then
And Alan's mic is unmuted.
It's not worth emailing them. So print them all and I'll take them maybe even this afternoon.
That's hilarious. Earlier you couldn't hear him at all. Now he's got it going and it's not even talking.
All right, I muted all of you guys. So the only point I was making is when you do, yes, you can. The question is can you add ROM with DRE? And the answer is yes. So the hierarchy is DRE first. That's the hierarchy. And then if you can't find what you need there and you can in ROM, then do that. That's what we did in this particular case. And then when you do, make sure it's whole person. And the only reason we added it and not combined it is because it said right in that chart, add it. It said it specifically. Otherwise, if you have two impairment ratings, you want to first make sure they're the same units. Typically, when you get impairment ratings for extremities, they're in partial impairments. And you usually have to add those to get a whole body. It's called a whole body. And then when you add that to another impairment rating, you don't add it, you combine it. The only reason I added it is that table specifically said add it, and it was whole body to start with. That's the only reason. All right, any other questions? Hit your mic, your red button.
So it tells you to use the DRE, correct, Paul? If you can't find it to actually fit in the DRE, then go to the range of motion model, run it, and see which one it best fits in the DRE is what I was told.
Right.
Okay. All right. Making sure I got 100% clarity.
Start with DRE, see if you can fit it in that one of the tables. If you can't, go to ROM, see if it fits there. And it's obviously it's going to be very, very general, like the case we just did. Nowhere in there. Well, what did they do? You know what? That was actually a really good example. Where in there did they have ALM or lateral alar ligament laxity? Nowhere. It was nowhere in there. Where did they have hyper lateral flexion, hypermobility, C3 lateral flexion? Nowhere. Where did they have hypolordosis? Nowhere. Where did they have absent cervical rotation? Nowhere. And where did the AMA guides have hypomobility that we had on lateral flexion C4 to C7? Nowhere. They can't. Why? They cannot include a book that has every disease and pathology known to man. That's why it's called the guides, not the rules. Does that mean if any of these problems existed, that there's no problem with the patient at all and they're 100% healthy? No, that's ridiculous. And that's why you have to get out of the mindset. So you're going to have a few items that will be there. A few of the mainstream. By far, the majority of them will not be there. And that's why you have to know the general rules. And then the general rules will kind of guide you to which ones you should use. The examples that I just gave you is I told you we could have used category 2 for the alar ligament. We could have used category 3. We could have used category 4, or we could have went over to the ROM table and we could have used it. And so I chose to go to category 4. Why? The significance of the injury, and it was most associated with ALMSI, although it was lateral flexion of the atlas and axis, not flexion extension. So it was most associated. That's called using common sense and guides. So that's why I chose that one, not category 2 or 3, because it was most associated with flexion extension LMSI, just a different anatomy. That's all. That's why I chose it. And then we had to deal with the other issues. If we wanted to add them or not, or, look like an impairment whore or not. And, again, a lot of guys, when they find out how to do impairments, they just start whacking the heck out of impairments, and they don't have the high sensitivity documentation, all the different levels of documentation to support it. Like, what we talk about, the bare minimum mechanism of injury, subjective, hybrid, and objective, MMI impairment, and at least have one primary in each one of those categories. That's what you should have for the most part until you actually, that's when you'll have a value case. So that's how we picked. I just logically went through the process is all I did. I went through the process of elimination, what fit the best, and there you go. And I'm going to say that in my narrative report. I'm going to say that.
Well, the guides do tell you to go to the highest value that fits your particular patient or injury.
Always.
So even though you could have used 2 and 3, that's not.
But be careful, because it could actually give you a better definition that's more specific with a lower impairment rating. But then you may choose not to do that and then jump over just because you want to give a higher impairment rating, but now it's not specific. See, now it would be very easy to challenge your credibility.
Gotcha. Make sure it's specific to that injury.
Yeah, we already know what chiropractors do. They try to be impairment whores once they learn out the basics of impairments. They don't have good documentation with high sensitivity, high relevancy. They don't know its relationship to the categories to stop lobe offers or to support high value award. And then they try to be impairment whores when they don't have much. That's what the typical chiropractor does. Now, most of them don't, because most of them don't know how to do it. But soon as they learn a little bit about impairment ratings, we're getting impairment ratings off the chart for some ridiculous little injury. It doesn't even make sense. And, because he thinks it's going to create more money. I'm like, no, but how many times have I said? It's the totality of your knowledge of how all these categories come together that creates the value. You would have more authority and credibility with an attorney by pointing out all these categories, and it wasn't as strong a case, and moving that person into a way more specific impairment rating that was lower than if you were to take and move them into a higher impairment rating because you thought it would get more money. That was not, but it's generic, it's not specific, and you didn't have very much documentation to support it. You'd have way more credibility from that attorney in the long term. In other words, how all this comes together. Because let me tell you, you do not want to get caught in that kind of case and then, it not be a good case or not a value case, and you were the impairment whore, right? Well, what just happened to his authority and credibility in you? But let's go to the opposite. You're now telling them why it's not this higher case. It's this lower impairment rating, and you have less documentation to show it, but this is where they're at. So the case settles for less, but it settles for less. In other words, now you're the authority and you tell them why. How does he feel about you now? In other words, if you were the attorney, which of those two doctors would you prefer to work with? The one who knew what he did have and didn't have and saved a lot of time and energy, or the one who's trying to make something out of nothing? Who do you want to go with? Well, that's what they do. So you can lose credibility fast. Like I said, I'd rather have 10 cases that are worthless, but I have the ability to walk through all of those cases and point out all the different documentation categories and the prioritization of those categories relative to that injury award, and show him that he doesn't have it, and this is why he does not have it. I'd rather have 10 of those and me go through 10 of them explaining why it's not a good case. In other words, I'm really selling him on me, not the case. That's what I'm doing. So he now understands, I know the value of a case, and therefore I will not be wasting his time. See, that's what they want. They want to know if you got the goods or not. If you got the goods, tell them. If you don't got the goods, tell them. And if you just have a little bit of goods, tell them you just have a little bit of the goods. That's what they want. That's what everybody wants. But that's not what the chiropractors do. They think they got to run in and hit a grand slam, and then they got crappy documentation. Typically, they don't even have impairment ratings. And then if they did have impairments, they become an impairment rating whore. Chris, you weren't even doing impairment ratings, were you? You weren't even doing impairment ratings prior to joining my course, were you?
No, I was not.
Yeah. Is there a reason you just didn't know the value of them, or what?
I just didn't know. Yeah, I didn't know the value. I didn't know I was
Okay, so you
uneducated about.
you didn't know that was an integral part of personal injury.
Correct.
Okay. And there's a lot of chiropractors out there like that.
I'm with Chris there. I did it for work comp for 10 years, but never a PI ever.
Well, you did disability ratings, not impairment ratings.
No, I did impairment ratings.
They asked for impairment ratings for disability.
They do an impairment rating, so it's a percentage, and then the disability is a judge and their factor over there. They just want the doctor to do an impairment rating in Texas.
Oh, I got you. Yeah.
So I am certified to do disability evaluating physician, spinal and stuff, but I rarely do that, if ever.
Yeah.
But I'd never done it before. Now, do you have to get authorization from the patient or the attorney before you do an impairment rating? Or
You don't have to, but it would be stupid to do one without it.
okay.
So you should be doing an impairment rating when it's requested from the attorney. Now, the impairment rating should be inclusive of the narrative report. So when the attorney asks for a narrative report, it should be included in the narrative report. He shouldn't have to exclusively give me an impairment rating. Now, remember, the attorney who does not know to ask for an impairment rating, that's somebody you have to educate.
That's probably 99% of them, Paul.
That's somebody you have to educate.
Okay.
They do not understand the value of the impairment rating relative to the case.
Gotcha.
And I call that what?
Opportunity.
I call that opportunity. Yeah.
100%.
Yeah. So when you get an attorney asking you for the notes, or especially if they don't even ask for a narrative, you have one ignorant attorney. You have an attorney who's in a state of unconscious incompetence. And you need to sit him down and do a serious educational sales presentation with that attorney. And don't follow their lead. You've got somebody who's ignorant and doesn't know they're ignorant. They need to be educated. Don't just give them what they want them and you stay ignorant. Don't do that. And a lot of times they don't know to get it, or they don't know the potential value of getting it. So when I have attorneys who don't ask for an impairment or a narrative report, when they ask for a narrative report, it's inclusive. And then when I don't, I'm like, oh, this guy is low end. Let's face it, you're not a trial lawyer attorney and not knowing the importance of impairment ratings. You get an attorney who doesn't ask for a narrative or an impairment rating, and they won't ask for an impairment rating. They'll ask for a narrative, and the impairment should be included in. So when you get an attorney like that, you're almost always dealing with a C attorney, somebody who doesn't know a lot about personal injury. What does that mean? It means you better get them to the presentation table as fast as possible and show them the relevance of how all this comes together. Yeah, look at this case we just put together. This is a fantastic case. And what would the typical chiropractor do with this? This is a sprain strain to a typical chiropractor. Typical chiropractor would have an excessive bill. This would be a sprain strain with no impairment rating and no narrative report. That's what the typical chiropractor would have done with this case. This good case. This is a high value, good case. And the typical chiropractor would have just ruined it because of their ignorance. Right, Chris? Isn't that what you were doing prior to joining me?
That's exactly what I was doing.
Yeah.
I will admit it.
Chris, you'd have missed all these major components, wouldn't you?
Every one of them. Yep. Sprain, strain, sprain, strain.
Yeah, there you go.
Yep.
Paul, based on your factor, if the person was 30 years old, going to work for 30 years, made $50,000 a year, that's a $170,000 case.
Right.
Wow.
Yeah. Remember, the prognosis and need for future care is typically the largest of the injury awards.
Yeah, that was my calculation was 140 twice a month, 280, 30 years, 100,000.
Yeah, and what they'll do is if they don't have like a regular job where you can calculate that out in, sometimes they'll just put them into the earned economic average. Like let's say they were stayed at home. Then a lot of times what they'll do is they'll match them with the national average of income for that region is what they'll do to come up with the numbers to multiply. In other words, if the person did work, what for their level of education, what would their income be national average for that region? Because remember, regionally it does differ. It's always for your region.
And that's something that we put together, not the attorney, correct?
No, you're putting it together.
Right, I know.
I'm sorry. No, the attorney comes up with the final number. You never come up with the final number.
Okay.
The number you come up with is what treatments were necessary, what was the frequency, and what was the cost of those treatments. Those are the numbers you give the attorney. And then he goes to the actuarial scale.
Gotcha.
And then he's the one, that when he goes to the actuarial scale, multiplies it out and gets that number. And you need to be telling him that, because a lot of attorneys will even ask you, they'll say, what do you think, the need for future care is? I'm like, well, you better tell them the formula. Say, well, I can give you this, this, and this, but really because now you're out of your field, and that'll look bad in front of a jury.
So once again, you're going to have to educate him on knowing what to do and do it next with the information you hand him. Because
I told the attorney anyway. I just didn't have it written down. I didn't have it written anywhere. I didn't have it in an email.
okay.
I didn't have it in my notes. What's in my notes is what therapy was needed, the frequency it was needed, and the cost of the therapy. That's it.
Gotcha.
But I would tell the attorney, and I would just Google, how old is he? And I just Google, actuarial scale, put in the basics, and then I'd multiply it out and go, okay, this is what it looks like. But I wouldn't have it written anywhere.
Gotcha.
He's the one that's asking for money, not you, the doctor. It doesn't look good when the doctor's asking for money.
Gotcha.
And you need to tell him that. He'll understand that.
Got it.
The lower ones won't. Remember, most of them are lower end. They're not used to these kinds of conversations that we have in our personal injury webinars. This is expert stuff we're talking. I could give this presentation I gave today in law school. This was an excellent expert witness case.
Yes, it was. And I can tell you right now, I've dealt with trial lawyers before that didn't ask me for 90% of the stuff you're telling me.
You just got to keep remembering they're not medical doctors. There's no reason for them to know all this. It's up to you to educate them. Just like there's no reason for you to learn how to write a brief. That's called opportunity. See, the big fear that all the chiropractors have is really the big opportunity. The big fear that they think the attorneys know more than they do, and they don't know what to say and all that. That big fear is actually opportunity, but most people are blinded by the fear. Let me leave it like that. But this was kind of routine stuff that we see week to week in a chiropractor's office with personal injury cases.